Hi, this is Dr. Henry Salama for Dental XP. Talking today, our subject is going to be immediate extraction, implant placement, and immediate provisionalization in the aesthetic zone. This is a second of a series, and what we're trying to do is really give you some guidelines on how the process evolved, at least in our practice, relative to the logistics of planning out this kind of treatment protocol and the most efficient way of applying it. As we all know, many of us on an everyday basis in clinical practice, we get patients who come in and for one reason or another, usually fractured tooth, a failed endodontic treatment, the tooth needs to be extracted. The question would be whether it should be extracted, grafted, and delayed implant placement, or whether we should actually attempt and actually make it beneficial to have immediate implant placement and even immediate provisionalization. Usually, as far as our team is concerned and as far as we approach it, with a thick, flat periodontium, when you have, as you see in this particular slide series, an intact socket, four walls, especially the labial plate of wall, when you have an ideal environment, what we would call a type 1 site. And this site, as you view it, especially on 3D imaging, is an ideal site because all the walls of the socket are intact. You don't have a fenestration, you don't have a dehiscence due to the particular reason that you're extracting the tooth, whether it's a fracture or an endodontic failure. This is an ideal environment to do immediate implant placement. With thick, flat tissue, immediate provisionalization is also indicated, and usually we try to do this in a flapless approach. Research has shown that when all of these factors are combined, a type 1 site, a flat, thick periodontium, then a flapless approach is the best way to preserve that type 1 site. And in the 1990s, the 98 in this case, I'm going to show you a case of how we used to actually treat this kind of situation. This is an external and internal resorption. The tooth is going to be extracted. We're going to actually drill the tooth out because it's ankylosed most of the way around the socket. This is a technique that we published on in 1999, which is actually to utilize taper drills to drill out an ankylosed tooth. Once the tooth is extracted and the osteotomy is verified that there are no perforations, no dehiscences, again, what we would call a type 1 site, an ideal site, we're going to go ahead and drill our osteotomy to depth and then place our implant. Any space that is remaining relative to between the implant body and the socket walls after the implant is put in completely, that area is grafted with a combination of autogenous bone taken from the osteotomy as well as either bioos or pure os. The implant is placed. This happens to be a Zyve implant that's going to be placed. We would then use an Ostel. You can see that this is an older Ostel, and look at a minimum of 40 Newton centimeters of torque that it takes to place the implant. That tells us that primary stability is adequate enough to consider immediate provisionalization out of occlusion. So looking at the ISQ is 57, that's quite high, or I would say quite high stability ratio. And we like to actually make our own custom acrylic copings that fit very well on the abutment of your choice, whether it's a temporary abutment or a pre-machined abutment. You can see that the acrylic coping fits on. It has all the marginal integrity and very good friction. We then use a polycarbonate crown former, very easy technique, something that we've actually designed early on to make it possible for your dental assistants to do this procedure. Because the coping gives us the margins, the polycarbonate crown to form. We will also take a shade guide at that initial visit and a final impression. So all that information is taken. We can literally go onto a final crown if we chose to. In this video right now, you're seeing the immediate provisionalization, and we make sure that this provisional is out of occlusion, both in centric relation and centric occlusion, and in all excursive movements. We don't want any kind of occlusal contacts during the early phase of osseointegration. This is then transferred to the model. As you can see here, the laboratory technician can choose their abutments and fabricate our final abutment and our final crown. And this was a technique used for many, many years, starting in about 1998 to about 2004 or so. And it's very stable. You can see in this video how stable the tissue is, a flapless approach where you maintain the periosteal vascularity, where there is no reflection, no trauma to the tissue. The tissue really, integrity and from a quantitative perspective, remains quite good. And it's a very solid technique from a logistical and clinical parameter standpoint that we can use to extract teeth that maintain a type 1 site after extraction. How do we continue the process today with some of the new trends that we have available to us, specifically 3D imaging technology that can extrapolate to CAD-CAM made surgical stents, as well as CAD-CAM fabricated abutments if necessary. In this particular case that I'm sharing with you, this is a patient that had previous restorations made, and the left central incisor had a fracture along the large post that was placed in that restoration. You can see a little radiolucency on the mesial of number 9. The big question for a case like this for me would be whether after extraction that radiolucency on the x-ray actually translates into a compromise of the labial plate. And very often it does. You can actually take a look at this kind of lesion and you'll end up having either a fenestration or a dehiscence of that labial plate. But the best way, if we can do it, we take a look at our 3D imaging. We'll take a 3D imaging of the site, and in this particular case, even though you do have a radiolucency and a defect, in fact, that labial plate is intact. And I can then go ahead and plan my restoration, and you can see the implant is in place, and not only plan where the implant will go in the socket in the three-dimensional planning, but also even the abutment. You can choose an angled abutment if necessary. You can choose the length of the collar that will be required to manage the subgingival space. And you can even get an idea from a dimensional standpoint, the distance between the buccal or labial aspect of your implant to the outside of the labial plate. And usually we want that to be a minimum of 2 millimeters. That's tells us that we should have a very stable dimension of bone that can support the soft tissue in a maintainable environment. Once we do the three-dimensional virtual treatment plan, we can then send this out to be converted. In this particular case, this was done with Implant software, the virtual treatment plan, and then sent out to Materialize to fabricate surgical stents for us. With the Materialize software, and there are many softwares out there, but with the Materialize treatment that we have here, they send you back a stereolithic model of the arch you're working on, as well as the surgical stents that reflect the implant system that you have as your treatment plan. You can see the surgical stent, the stereolithic model. Today, what's possible is for us to actually take that information, and before the patient is in the chair, we can virtually transfer that implant position to either a lab model, a stone model, or the stereolithic model itself, and have the laboratory put in a laboratory analog for us. What that allows us to do is literally go ahead and not only look at and view again not as a virtual aspect or concept, but in a physical model, you can view the position of the implant and even choose a final abutment. And I think this is a very, very powerful tool today, because it's a concept that's based on some of the work of Abramson and co-workers at Gothenburg University in Sweden in the late 90s and early in 2000. And the concept we termed as one abutment, one time, that if you can treatment plan adequately and choose the abutment prior to going and doing your surgical procedure, you can have and place the final abutment on the day of extraction and implant placement, and therefore never have to take it on and off, and all the procedures are required with temporization and impression taking. And this allows you to keep that abutment in place and maintain the junctional epithelial attachment without any trauma that usually, as the research and the hypothesis tells us, would then push that attachment apically. So one abutment one time tells us that if we can place that final abutment on the day of implant insertion, we would get the best, most stable tissue integrity. And you can see it here. In this case, we chose a zirconium abutment that is pre-contoured anatomically to give us a good chamfer margin, subgingivally about 0.5 millimeter, and follows the contour of the soft tissue. We'll have a coping similar to the previous case that you saw, polycarbonate crown, literally have everything available to us so that on the day of the extraction, we already know what implant size and length we're using. We have a final abutment chosen, and we even have the temporary all made even before the patient sits in the chair. You can see here the extraction is done. There's that vertical fracture on the mesial of the central. The implant is placed and with an internally hexed implant. And the final abutment that was chosen preoperatively is put in place. A zirconium pre-contoured abutment in this particular case. This is a Xive implant for Dentsply Tulsa, and the customized final zirconium abutment is put in place, and temporization is finalized. What I'd like to do is show you the video of this procedure in real time. Literally the day of the surgery, we actually go in and have all the components ready that you've seen previously, the surgical stents, the stereolithic model, the components that we use to fabricate the abutment, prepare the abutment, and the temporary. The abutment is in place, and the temporary restoration is also provided for us, as well as an impression coping if we so chose. So the surgical stent is in place, the implant is then put into place, the different drill sequence that's required, the 2 millimeter drill, 3 millimeter, final osteotomy is fabricated, and the Xive implant is put in place, and the final abutment that was chosen is put in place, and the temporary. Usually the procedure, as really well planned logistically between the surgeon, the restorative dentist, and the laboratory, the whole procedure sometimes can take as little as a half hour. Here we are with the temporary on the left part of the screen is at 8 weeks, as well as on the right, and you can see that the contours of the soft tissue have remained intact, the flapless procedure. The labial plate was intact after the extraction, so just grafting the internal aspect of the socket, as well as putting in a connective tissue graft right at the neck, has been able to maintain the integrity of the dimensional integrity of the soft tissue, both at the gingival margin as well as buccolingually, as you can see on the right part of your screen. 8 weeks later, we took off the temporary. Again, look at the integrity of the buccolingual dimension of the ridge is comparable to the adjacent tooth. And now we can go and take our final impression. And we do this, for this particular case, we had zirconium CAD-CAM transfer copings made with a notch on them that fit the abutment that we had chosen preoperatively. So we can put that in the mouth. There's a notch so that it would actually remain in the impression material. And without having to remove the abutment, without having to use cord, We just transfer that dimension, and that notch eventually will be removed by the laboratory technician, and the final adding of the porcelain to this zirconium coping can be done one abutment, one time being the concept, never disrupting that initial placement of the abutment. And you can see the transfer coping, which really ends up being the core zirconium component to our final abutment. These are actually your actual margin for the final restoration. And always, whether it's the temporary or the final restoration, the subgingival contour is usually either flat or concave until you get to within 0.5 millimeter of the gingival margin. Only then do we come out to the final contour of the crown, or pretty close to it, as you see on the right part of the screen, and we call that the submergence profile. We want to maximize the amount of space for tissue and not overburden the tissue with over-contouring it. So to preserve that tissue around implants, in most aesthetic environments, you'll find that we will try, especially in the temporary, and sometimes depending on the tissue consistency, thin scalloped periodontium, we'll have a flat or concave submergence profile as exhibited on the right part of the screen that you're watching. And now we can go and you can see the final restoration on the right part of the screen compared to the immediate provisionalization that was done on the day of extraction and implant placement on the left part. And for the most part, we've actually maintained and preserved that initial tissue contour. In fact, I would suggest that the color and consistency of the tissue is even better. So good planning, the right components allows us to preserve a type 1 site and to be able to do an extraction, implant placement, and immediate provisionalization out of occlusion in a very, very stable and predictable fashion. Next time, as we move into even more difficult areas of fully edentulous maxilla, we'll use some of the techniques that we've spoken about in the previous 2 sessions on immediate loading to really try to apply and even take the concepts of 3D imaging and CAD/CAM technology and provisionalization and patient management to the next level as we see it today in private practice. You can see on the left part of the screen now is your initial preoperative x-ray with the defect around the fracture, the final x-ray, as well as what we do in our practice, which is follow up and look at these in 3D imaging, CAT scan, dent scan technology. You can see that we've maintained the labial plate on the implant, and also the soft tissue dimensions. We can look at them and see how we've maintained it. So collecting clinical data, following it up, evaluating our work today is that much more accurate, and we can see how we can improve these techniques as we move forward. I hope this has been helpful. Certainly I look for you to join you and in discussing this very, very important and very relevant topic to everyday practice in another session. So thank you very much.